Now, the future of medical aid schemes post the COVID-19 pandemic hangs in the balance. There are fears that a number of people will be forced out of medical aid schemes as there are projections of major job losses as a result of the pandemic. Now, it is estimated that millions of people will be retrenched and salaries will be slashed after the national lockdown. And this is mainly because companies would have lost their profits. Now, Dr. Donald Gumede, a medical doctor and chairperson of the National Healthcare Professionals Association, joins us for this discussion. A very good evening to you, Doc. Now, looking at the profile of people who are on medical aid and part of medical aid schemes in South Africa, about 15% of South Africa's population, already we are starting to see retrenchments. Already we are starting to see people lose their jobs. Is this something that the medical aid schemes can actually cushion? Do you have any sort of contingency plans in place?
Good evening. I don't think they do, because if you look at it holistically, the medical aids were actually going off the roof. Their prices were very high. Even under normal circumstances, many people were not even affording to be part of the medical scheme industry. That's why we were talking about NHI, which actually was supposed to come and neutralize the soaring prices of the medical aids. And with this COVID-19, I think it's going to naturally kill the medical aids, because many people won't be able to pay for them. I mean, now it's about the question of bread and butter. People are now looking at what is essential from their salaries. I don't think paying hefty medical aid bills is going to be part of that equation. I don't think so.
Let's look at the cushioning that medical aid schemes have in the event of there being an oversubscription. What type of cushioning do you have? I mean, you do have the reserves. Are those going to help in any way?
Good question. Those reserves, actually, they're supposed to be around, I think it's 25% of the reserve from which is required for them to do. I don't think it's going to be enough, and it's going to run out in any way within a few months, even if they do have those reserves. And the bigger picture, if you look at it, I think now they're still a little bit cushioned by the fact that the hospital industry is not fully functional, if we may put it that way. They are maybe functioning at around 25 to 30%, because majority of the hospitals are not functional at this point in time because of the COVID-19 and in preparation of that COVID-19. So, meaning the bulk of the money that the hospital used to claim is lying with them. So they still have that money. But I'm not sure for how long will that equation last, because the fact of the matter is, as the COVID-19 continues, when we resume normal life, many people won't be able to afford medical aids, and it's a fact. And in that way, then we're going to see the medical aid industry spiraling down, I think, into bankruptcy.
So there is there is another option, Doc, for medical aids to actually start reducing the premiums that they charge. Is that a possibility?
They will never do that.
So
I can well assure you, they will never do that, because remember, every year they increase their medical subscription by whether 6% or 7%, depending on which medical aid you are subscribing to. And then they will be telling you it's in accordance with the inflation. So they won't be able to. I think many people, what will do, of which is something that we have been talking about, is many people who will end up having what we call hospital plan, meaning they only subscribe to only when they are hospitalized. But like, we should not estimate the value of the NHI, as I've already alluded to, because that was to seek to try and include everybody at a lower rate, because NHI it will come at a lower a price tag as opposed to your medical aid at this point in time.
And we'll talk about the NHI in just a moment. I just want to finish with the medical aid schemes. So
Sure,
you're saying
sure.
that they would rather close shop than reduce the premiums that they charge?
Yeah, they will rather be, because you remember, and this is what we have been fighting with, if you remember, from the National Healthcare Professional Association, that actually the medical aids, they were not playing fair with the healthcare professional, and they were not playing fair as well with the patients themselves, because majority of the money was going to their executives, if I were to put it that way. So it was not actually going to the healthcare system, where maybe it's the healthcare professionals who are benefiting or the patients who are benefiting. Majority of the bulk of the money was going to the pockets of your medical aid administrators, which actually is not right. So for them to actually reduce, like you rightfully say, the premiums, it means they have to take money from their pockets and redeploy it back to the patients and the healthcare professionals, of which I doubt if they will be willing to do that.
Well, it certainly is a space worth watching now to see if there is some sort of a survival strategy that will be put in place for medical aids. But to the NHI now, the big question is, and I guess the big concern, is it's taking far too long.
Yeah, actually, just to answer you properly, it's not taking too long. We have already started NHI. It's just that we don't appreciate the country as it is, because you see, if you go to the hospitals, your hospitals are for free. It's just that our level of or the standards in our public hospitals are not of that of the private hospitals.
And that is the main issue, because what you want is premium healthcare across the board. We don't want want a dilapidated public health system, but we want something that will service all of South Africans in the best possible way, and that is not something that we are seeing happening.
Yes, correct, 100%. And then that's why we're saying that if we were to improve we all want beautiful things. If we were to make our public hospitals top class or 5-star, we'll all go there, because it's for free. You get Panado for free, you get antibiotics for free, you get everything for free through the government. Now, if our government is able to provide such systems, now the problem was it's budget, because they do not have enough budget to leverage so that they can improve our infrastructure, like our hospitals, if we were to put it that way. So if we have the NHI, and if it's managed, and we emphasize this fact as the NHCPA, to say it must be administered by people who are willing to sacrifice for the country, not to put money into their pockets. Because if you have got people who actually are there or out there to improve the level of our infrastructure in our public sector, and are able to put human resource very well in the public sector, so that you don't wait for the whole 24 hours just to be seen by a doctor, because that's one of the key things. Because if you go into private, you know that if you go at 11, by 12 the doctor has seen you. But if you go to our public hospitals, you go there at 8 o'clock in the morning or 7 o'clock, you'll be seen at 10 o'clock in the evening. And that's not good. And that's what actually we are trying to say. With NHI, we have to pool all the resources and make sure that financially it's sound, and also infrastructure is also sound. We also have medication to our patients, as we do now, but we don't have enough medication in the public sector.
So let's look at a practical scenario now, Doc. Here we are right in the midst of COVID-19. When COVID-19 does end, people start losing their jobs, can no longer pay for their medical aid. What solutions do they have now if they're not on medical aid, but we don't yet have a public healthcare system that is able to give them the type and quality of medical care that they're used to having? What are their options?
Yeah, that's a very good question. I once said, when I was having the interview, the first time when COVID started, I said we are actually in a war. So when you are in the war, Mangubeni, it's very difficult to actually predict the outcome of what's going to happen and what's not going to happen. We are in a war zone, to tell you the truth. We are actually in the middle of a war zone. It's just that this one is a biological warfare. In truth, there will be lots of casualties, and we are fortunate that, and I'm emphasizing the word fortunate, that we are still at around 600 or so of death under the pandemic. But then you see, in the war, majority of people, like the Spanish flu, 50 million people died, perished. I mean, they were lost. The families lost such a high number of people. But then you see, now you have a situation whereby now COVID-19 is here, and then I think we're going to suffer not only medically, we're going to suffer even socially. Like many people under war, you'll have your malnutrition, you'll have other diseases which will spring into action. And so we might actually experience huge devastation of other diseases other than COVID-19, which are associated with actual poverty in the long run. And we are looking only at COVID-19. I always say to people, we still have our TB, we still have diabetes, we still have cancer, which is ravaging our people. We still have a high blood, which is actually killing our people. But then you see, if you look at it intensely, poverty, I think, is one big element that actually we should be putting aside some money. Like in America, they've put trillions of dollars aside to try and as a contingency plan. But ourselves, I'm wondering if we, as a country, we have put or stock up enough food so that we can look after our people. Because as you rightfully say, it's not what's going to happen to someone who doesn't have money after COVID-19 and they need to see a doctor. They have to see someone. And unfortunately, NHI, it's not yet in fully function, as you rightfully say. But then we have to look after each other, to be honest with you, as the healthcare professionals. That's what we are good at doing. Now imagine it's under COVID. We are up there in the forefront. We are fighting the virus, putting our lives at risk because we saw to serve the nation. So we're not gonna all of a sudden abandon our people. And I'm not saying that we give free services as private healthcare professionals, but we do see people for free, and that's a fact. So if someone is... Yeah.
Sorry, before I let you go, our time unfortunately is running out. What is going to be the impact of those who do stay on medical aid? Obviously, that number of 15% will drop should there be large unemployment. So what will be the impact and the result of that for those who can still afford, those fortunate few?
Unfortunately, they will have to pay high premiums. Because remember, schemes, it's like a group scheme. You are subsidizing each other in the scheme, in the medical scheme. So the fewer the medical aid members are, I think the more premiums that they will have to pay. And that's the burden of it, unfortunately. So they're going to have a very serious burden to carry. But then I'm pro-poor. So I'm looking at the poor people. They are the ones who are going to be impacted more because they are actually the ones who need more medical help than actually the rich. So you'll find that majority of the guys who will be left in that medical aid bracket that you're talking about are those who can actually afford. and those who can afford, they will be spit out of the system.
And inevitably, there will be more of those who cannot afford. We thank you so much for your time and your insight this evening, Doc. Thank you. That's Dr. Donald Gumede from the National Healthcare Professionals Association. He's